Welcome to the Health IT panel session. And I think the way we'll do it is we'll go ahead and introduce the panel. And after we do that, each of us will present about 10 to 15 minutes worth of material. And I will show the order on the screen before we start. By way of introduction, I'm the medical director of the Innovation and Advanced Technology Group at Kaiser Permanente. Kaiser Permanente is the largest integrated care delivery system, non-government system in the United States, with about 9 million patients, about 167,000 employees, and revenues of about $46 billion. The IT budget is about $3.5 billion. So in our IT group, we look at new and emerging technologies that coming to healthcare in 2 to 5 years, and that's what we've been doing in our group for the last 6 years, looked at over 1,000 technologies. We also have a Garfield Innovation Center, which is in Oakland, and does a lot of simulation of space design, workflow design, and technology testing. I've been at Kaiser for 30 years, and also have gotten an MBA from Berkeley, and I've earned my, done my training in pediatrics. So if you're under 18, you can talk to me. I can talk to you. Of course, in the area where I work, you know, people say, why is a pediatrician in there? Well, you know, we like to play with toys. so I look at a lot of toys. But there is a serious side to the business as well, and we hope to find out some of that today. I want to introduce from my right, your left, is Mr. Ajit Singh.
Okay. In the next 10 odd minutes, I'd like to cover 3 broad topics. I'd like to start with an example in radiology, which was the earliest beneficiary of healthcare IT. From there, I'd like to go into what I would consider 10 key things that healthcare IT ought to achieve in the next 15, 20 odd years. So I'm looking at a 2-decade agenda. And finally, there's a call for action slide that's not in this deck, but I'll be able to talk through it, should not be a problem. So radiology was a field that started going digital about 20 years ago. So why was radiology such a forerunner in healthcare IT? A couple of factors. Number one, it's one of the more technologically advanced fields of medicine to start with, so given the nature of technology that goes in. Radiologists have, in general, been early adopters, and those 2 things helped get this to happen. If you look at the list here, the lower half focuses on what happened to radiology once it became digital, and those examples are the kind of things that it was possible to do faster, better, cheaper, less expensive, more efficient, and so on. So for example, productivity going up, turnaround time going down, study availability going up. Those are classic examples of what happens when you have high availability in a system. Whereas if you look at the upper list, that list speaks to what was possible now that was not possible before. So an example would be, if you go for an X-ray exam or an MRI, you often have to compare images from the past to the present. And when these images were available in a film form, that comparison obviously wasn't done very often. Even though it was clinically indicated, it was done only about 3 to 4% of the time. And when the system became digital, that comparison was being done nearly 100% of the time. So which means that something that was clinically indicated, that was always required, it was not possible before, but it was possible after you had availability digitally. Similarly, if you have to fuse images from multiple sources. So if an MRI image has to be fused with CT image, not possible to do it on film, but is possible to do once you have them digitally. No, not very different from what you would do in Photoshop. And of course, that allows for better, higher levels of diagnostic quality. If I go a step further and kind of put labels around those 2, the lower list is the list of things you could do quicker, more efficient, or at lower cost. The upper list is a list of things you couldn't do at all. In the healthcare parlance, you will call the lower list automating the standard of care, the upper list redefining the standard of care. So this is a key slide. As we think of healthcare information systems, there are many, many things we'll have to do that simply automate what's being done today in an inefficient manner. That's already a lot of value. But it's intellectually not very stimulating. It's not rocket science to put together infrastructure in place, to put some workflow tools in place that simply automate what's being done very inefficiently. But the real value comes a level above when you have analytics, when you're able to bring knowledge to the point of care, then you are able to rewrite the standard of care. You are able to redefine the standard of care. That's where a lot of inherent value, medicinal value will come from. I will skip a couple of slides and then come to my second vignette, which is what do we expect to change because of digitalization? What do we expect to change because of healthcare IT? And I have picked 10 broad trends. Now, if you go through 1 through 10, you'll find some of them speak to infrastructure, some of them speak to applications, and you'll wonder why is there no structure to it. That's by design. I'm avoiding giving it structure because it's so preliminary and the area is so complex that any effort to do some reductionism is going to make us miss out on some things. So hence, it's a very unstructured list, and each I'll illustrate through an example. First trend is integration across the value chain. Best example, if you have, God forbid, a stroke, in Helsinki, they can take you from your door, to a needle in your brain in 26 minutes, no matter where in Helsinki do you live. In the US, our average time is about 4 hours. So why is Finland able to do it so much better? It's truly through an integration across the value chain. So the moment somebody's picked up in an ambulance and they know it's stroke or they suspect it's stroke, a CT is run, a head CT is run there, that information is wirelessly transferred over to the hospital. There is synchronization of this ambulance system with the traffic light control system of the city. So all traffic lights are given green for this ambulance. And when the ambulance arrives at the hospital, the ER physician knows whether it's a case of a thrombolyte or this requires a needle going in. All of this could be achieved in 26 minutes. This is a great example of what it would mean to have an integration across the full value chain. There are hundreds other examples, and you will see they come from very diverse use cases. Simple things like, do I have to fax a report, or can the report be integrated, or the fax function could be integrated into the system where I dictate my report? That's an example of end-to-end integration. So the example can be very mundane to very life-saving, but they are nevertheless all examples of end-to-end integration. Second is disintermediation of value chain. So if I have a pathology image in India, there's no reason why it could not be read by an expert at Fox Chase Cancer Center in Philadelphia. So you are essentially taking a value chain where a pathologist is tied to a microscope that is tied to the place where the slide is being produced. Physically, you are breaking that value chain and putting it together again. Personalization, I'm sure anybody who's attended any talk on healthcare, you've heard that word to a point of being nauseated. Personalization is much more complex than it mostly is made to sound. It's extensive use of knowledge brought at the point of care. And that knowledge is emergent. Its knowledge is not coded in if-then-else rules. The knowledge is derived from the data emergently at the point of care. Super specialty-based model. So it's well understood, the 10,000-hour principle in healthcare is well understood. The more of some procedure you do, the better you get at it. And that speaks to a super specialty model. So there is no reason why, if a town has only one case of a certain disease per year, obviously it doesn't make any sense for a physician of that specialty to be sitting in that town. So that case could be brought to where the expertise sits. Will require extensive use of information technology. Now I specifically call for integration of a very particular diagnostic tool. A lot of diagnostics today is morphology based, whether it's radiology or pathology, it's looking at structure. There is also some information that's looking at function, whether it's through MRI or through molecular imaging. Integration of those will require extensive use of information technology and informatics. Sixth, specifically two branches, one that has been a beneficiary of IT 25 years ago, the other that has had absolutely no, as a first order of impression, zero use of information technology. That's pathology. To bring these two together will significantly enhance the diagnostic value of either of the two tools. Seventh, across the medical record, it's obvious. The level of fragmentation of medical record is known to all of you, so I'll skip that. Efficiency will remain a key driver. Informatics will no longer be an add-on. It will no longer be an add-on to a function which is already there in a hospital or a outpatient-centric care. It will emerge as an integral piece of medical practice. And my last trend is the education in healthcare will have to change very significantly. So I give you one instance. If you get care in community, the guy who's giving you care is using information that was published about 20 years ago. If you get care in an academic medical center, the guy who's giving you care is using information that was published somewhere between 5 to 10 years ago. And it's only if you happen to be with the one authority in the field, he or she is using information that was published less than 5 years ago. So why is it that a paper that was published yesterday in Australia on population of Papua New Guinea could not be utilized for you in a very personalized manner? To do that, of course, technology will have to enable it, but the education system in medicine will have to change very significantly as well. Collaborative medicine will become far more key. It's a complement to the super specialty model we just talked about. Final slide. Why is this so complex? So number one, the number of use cases is very large. So the use case I gave you for stroke is just one use case. There are over 5 or 6 million such use cases in routine medicine today. What's worse, they're highly interrelated. So you can't take each use case on its own merit. They are highly interrelated. The number of stakeholders is very large, and they are also interrelated. And finally, the number of variables is very large. So I was giving an example yesterday that to deliver or to decide how much radiation dose to give to, say, a patient who has a stage 2 prostate cancer requires correlating some 35 variables. And that's just one example. Imagine, and that's just one sub-class of cancer. Sub-class. That's why this field is so complex. And so I have a call for action slide that I'll try and concoct. By the time we get through the 4 speakers, I'll rejig my thoughts and present it at the end. Thank you.
Okay, next we have myself, which I'm going to talk a little bit about big data in healthcare. And I speak from the perspective of a physician who's also a technologist. What do we mean when we talk big data? We're now talking about gigabytes, terabytes, petabytes, and how do you remember the last 3? Exabyte, zettabyte, and yottabyte. It actually spells easy, E-Z-Y, so it's easy. Digital data is growing at 62% per year. But the interesting thing is that most of that growth is in unstructured data that is not neat and clean and in sort of clean fields that we can analyze. Structured data is only growing at 22% per year, and the rest is all unstructured. And one fun fact is that how much data did the whole world generate per year? In 2010, it was estimated to be 1 zettabyte. By 2014, it's going to be about 7 zettabytes. So each year, here's one perspective for a physician. Each year, about 1 million articles are added to the 20 million articles that are in biomedical literature, and Ajit was referring to this. But today, the articles are different. They contain a lot of other stuff in them, addenda and tables and figures and appendices. In 1912, a physician could actually master all medical knowledge. All medical knowledge. In 2012, your physician must keep up with over 10,000 diseases, 3,000 medications, 1,100 lab tests, not to mention all the best practices that have been defined. And that's actually one of the reasons it takes a long time to get from research to practice, although that is shortening. And one study estimated that a physician and epidemiologist needs about 21 hours of study each day just to keep up. So forget about sleep, forget about practice. And thus, most physicians fall behind. It's a big issue. So in the 1950s, data was seen as a product. In the 70s, it was seen as a byproduct. In the 90s, it's seen as an asset. And today and beyond, it's seen as a substrate, something we can work on. So when we talk about big data, we're really talking about how businesses use data to produce information and use information to improve your decision making. How do we define it? What is big data? Data sets that are so large that it cannot be handled by standard data tools. Currently, the limit is about 3 petabytes, but of course that's a relative criteria. In the 80s, the limit was tape robots, and it went to Unix workstations, compute clusters. Gartner had an interesting definition. They call it the 4 V's, which is volume, velocity, variety, and variability, which is sort of self-explanatory. Basically, a lot of stuff coming very fast, your decision window is very short, and the stuff is very heterogeneous, hard to handle. So here's some examples today. There are thousands of sensors today that monitor air and water, weather conditions all over the planet. Complex models have been developed to predict the effects of all these weather conditions, these emissions, and so on. A second example is the intelligence agencies actually collect data today in real time from many different sources, and their challenge is to coordinate data between this source and that source. You know, you have something coming up in this area, and in another route you have something else, and how do you make the link? Of course, the World Wide Web is another example of lots of text that we can analyze, and Google has made a science out of this. They actually study the location and timing of searches on Google, where they find influenza outbreaks about 1 to 2 weeks before the government does, with 97% accuracy. And they also do the same thing for unemployment trends, 1 to 2 weeks before the government does. And of course, the FDA has put forward an initiative called the Sentinel Initiative, which is a voluntary post-marketing drug surveillance using data shared voluntarily by healthcare organizations. And one example that involves Kaiser is Vioxx, which is a drug that was approved in 1999. And Vioxx was a drug for arthritis. It passed all the FDA screens and everything, came out and sold to about 80 million people, making about $2.5 billion a year for Merck. But there were some red flags, some concerns. So KP, Kaiser Permanente, and the FDA actually studied Kaiser's 1.39 million KP members for a year to find out that heart attack rates and sudden cardiac death tripled in people on Vioxx compared to another drug. So they published this study 2004 in August. September, Merck pulls Vioxx off the market. So what was the final result? Probably Vioxx contributed to 27,000 heart attacks or sudden deaths and up to 140,000 cases of heart disease. So where does the data come from in healthcare? Well, it comes from consumers, and phone calls, encounters, a lot of unstructured data, emails, and so on. It comes from data collecting devices that are producing data in formats that we don't know yet or will come in the future. A lot of different things, physiologic sensors, imaging, and everything in your house is smart. You know, smart TV, smart cars. In fact, this year in Las Vegas at the Consumer Electronics Show, telematics was very hot, which is car automation. Can sense when you're getting sleepy, can sense when you're having a heart attack, drive you to the closest hospital, that kind of thing. Maybe one day. EHRs and other IT systems, a lifetime of blood pressure readings every 10 days is about 6 terabytes. That's just one measurement. Blood pressures are just a small part of the clinical record. Everything else in that record is also requiring analysis. New biometric data sets. Marc will talk about the genome. It will require a lot of storage, require a lot of processing capacity, and you're just talking about the genome, not about all the other stuff that are omics, you know, the proteomics, the metabolomics, and biomics, and things like that. And of course, data also comes from the usual sources, organizations, like employers, like public health organizations and payers, comes from research. I mentioned the research example, and from the web, sentiment analysis, emerging disease patterns, and so on. And as I mentioned, if you look at the data in the EHR, about 80% or higher is unstructured, which means that physician notes, streaming biometric data, web logs, images, social media, this stuff is really important. You know, when we make analytics, when we do analytics on data, we're really only looking at 10 to 20% of the data in the EHR, things that are well-defined, that are understood, that we can run the traditional tools on. But in the future, there's too much value left in the data that's unstructured. And that's been a challenge, and that's where people are starting to use new kinds of tools. And the second thing I want to point out is healthcare data is really complicated. It's really complicated. For instance, in Kaiser, we have 8 different regions, and in one region, there's 7 definitions of gender, which is amazing. Another region has only 2 definitions of gender. How do you harmonize? And that's just for one simple demographic data. The analytics, Google published in 2004 on something called the Google File System and MapReduce, using massively parallel configuration for linear performance scaling. And this was very suitable for cloud-based computing. And then in 2006, MapReduce got incorporated into the open source Apache Hadoop, which we hear a lot about today. There are actually conferences on Hadoop and a lot of startups using that technology in one flavor or another. And the main thing about this technology is that the linear scalability makes the cost of the increased capacity required predictable, and that's very important for business. Conventional approach to analytics is very much, the data is formatted very cleanly, it's scrubbed, it's very well understood. The problem is you have to know the question you want to ask, and you have to know the kind of answer you will get back, and you have to know that ahead of time. With big data, it's sort of the format and structure is not so important. You can actually look at the patterns of data, and then you explore the areas of interest. The problem with that is it's good because you lose less information that you're looking at, but currently the big data tools are basically for techies, very difficult to use unless you're very well versed. So the same issue goes with conventional analytics and with big data analytics. And some of those tools you'll see in the list is things like, you'll see things like columnar databases, NoSQL, distributed file systems, using things like machine learning, artificial intelligence, data mining, and predictive analytics. Those kind of terms sort of going with an analysis of unstructured data. And with the recent survey of CIOs, the biggest issue with that is this issue of, can end users use this? 46% of CIOs said that they didn't have enough staff or expertise. That's a limiting factor. So can you imagine in a company like Kaiser where we have lots of data, we've been collecting data about 1 to 2 terabytes a day since 2003, that if you had to get a data scientist every time you want to ask a question, you probably wouldn't ask a question. It would be too difficult. So one of the areas that startups are looking at is very interesting, is how to make this big data analysis even more scalable by allowing the end user to come in and do very simple queries without knowing a lot of data science. Does big data actually exist in healthcare? Well, no. We have a lot of silos. Some people disagree about ownership, resistance to what it might show, and the fact that we actually throw away a lot of data. Or you can say yes, and there are areas in care delivery, operations, public health, and research. Those are the 4 main areas you see big data. And in care delivery, you see the usual suspects like clinical decision support, analysis of quality, analysis for reporting purposes, operations, many of it coming from other industries, public health, and in research, especially in clinical trial recruiting, predictive modeling, and analysis of disease patterns. So here's some new business models that some people are coming in with. You can actually take the big data and you can de-identify it and you can sell it after you analyze it. You can use self-service, you can look at scalability as business models to support big data, but it's not a panacea, and this is my last slide. Automated discovery, which is the way that people are approaching big data, changes the way you learn. You think about how human beings learn. You look at data and you see patterns and you make associations. If you automate that, then your learning is constrained. So that's an issue. And some of these tools really have limitations. For instance, you lose context when you use big data tools. Claims to objectivity notwithstanding, accuracy and bias may be questioned. We have human researchers. Human researchers are always biased. And bigger data, not always better data. Google has found, for instance, that if you use a Google search, it does shape the way that you think the right answer is, because you see all the way it's ranked. And not all data are equivalent. A Twitter relationship probably is not the same as a personal relationship, although more and more people are going virtual these days, so maybe that is a normal relationship for the future. Just because data are accessible doesn't make it ethical to analyze it. And finally, it does create new digital divides, which is disparities between different groups.
If you look at the amount of information, so we have a blogger in the room that's probably doing a tweet per second as we talk. 200,000 minutes are spent every day with folks playing Angry Birds. But if you look at from a healthcare perspective, and the picture on the right-hand side, that's a picture of Dr. Sidney Cash. He heads a cortical physiology research lab in Massachusetts. He's looking at using big data to come up with therapies on how to best handle brain injuries. So how do you then take the edge of technology, not just to the fingertips on your keyboard, but to the neurons in your brain? So Jan touched on it a bit, but at HP we look at big data in 4 dimensions. So of course, volume, velocity, variety, but we call it complexity. And so if you look at the complexity in the example that we just gave about Dr. Sidney Cash, so imagine taking an MEG or a magnetic magnetic encephalography image, an MRI, a functional MRI image, an EEG, and using all of those pieces of diverse information to kind of drive inferences on how the brain works, how the brain synthesizes language, what happens when there's an injury to the brain. Health and life sciences is an industry in crisis. So spending is growing, innovation is slowing. If you look at the pharmaceutical industry, last year I believe there was only about 16 new drugs that came to market. Reform is accelerating, the government is driving acceleration, and the patients are demanding more. They want more out of their healthcare dollars, they want to be healthier, and they don't want to be in the hospital. Oops. So if you look at the amount of information, Jan talked about electronic medical records, lots of unstructured data, but because of that unstructured data, poor information equals poor quality. So imagine the different interpretations of gender that Jan just talked about, but then take it into the physician's notes. The physician writing notes in one context may be interpreted differently in another context. So I'll give you an example. Earlier last year, I was very sick. And the doctor prescribed a medication for me, and it was a super antibiotic, but one of the side effects was ruptured tendons. So I actually, had ruptured tendon, and I ended up at the end of the day. And treatment, I actually had 3 ruptured tendons, one in my hip, one in my foot, and one in my hand. But each time I engaged with the doctor, I said, there's something wrong here. There must be some complication of a drug, and so can you, kind of take a look at it? And then at the end of the day, he popped open, did some research, and did find that 12-year-olds or teenagers have this complication. Well, my wife thinks I'm a teenager, so I guess I fall into that category. Certainly. So if we look at the healthcare industry, we see a convergence of the healthcare providers, the health plans, and life sciences to drive systems of engagement. Me engaging with my doctors, engaging with the pharmaceutical companies to drive health and wellness as opposed to sick care. So if you think about it in 2 dimensions, much of our energy is spent, focusing on acute care. So how do we then drive that approach to systems of engagement in a wellness setting? So if you look at the amount of dollars that are spent in healthcare, we want to be able to keep people out of the hospital, out of the doctor's office, and in their homes making the right choices for themselves. So if we look at all of these technologies, what we see is a big move to systems of engagement. And what I mean by that is if you think about electronic medical records, electronic health records, research papers, and so on, those promote efficiency. They don't necessarily promote effectiveness. So if we can bring together all of those information sources in big data to drive a system of engagement, to pull the right information at the right time to deliver the right care for the patients. I use this picture because it's kind of interesting. Ajit talked about a stroke patient. So the example in the lower left-hand corner, we have RoboDoc that made his first rounds in Folsom, California, where he's sitting, in his office at home, and a stroke patient is brought in, and he actually gets to see him real time without having to drive 30 minutes to the hospital. And driving that effectiveness of care as opposed to the efficiency. For consumers, healthcare is getting personal. They want a choice, they want transparency, they want empowerment, and they want experience. They really want healthcare to be treated as a business, and they want to be healthy. So if we look at the healthcare technology, we see a convergence. Convergence of facilities, convergence of the medical care that they get, and communications between all of the resources. And so the resources aren't just the facilities and the beds and the drugs. The resources are also people, and taking and using all of the technology available and converging those assets in a way that drives that effectiveness is where we see the industry going. So if we look at the value driven by technology convergence, it's all about the patient. It's the patient's point of view. So big data really should matter in delivering outcomes to the patient. But the patient isn't the only answer. There are other stakeholders involved, and those outcomes need to be focused on as well. But ultimately, healthcare starts with you. It starts with the patient. Whether it's best-in-class analytics of that big data. So imagine a doctor now in the early part of the 19th century knew all about the healthcare information, and now they barely scratch on the surface. What if we were able to proactively, without having to search, be able to pull the relevant information up from relevant medical journals and match it up to that patient's circumstances in a clinical setting, real time? That would drive effectiveness. So if you think about harnessing health information, it really is taking, if you really think about harnessing health information, it's taking it from a variety of sources. Jan, gave us a litany of sources, and we need to be able to drive technologies that are able to contextually consume and deliver that effectiveness with the patient in the circumstances that we find themselves at a given point in time. So ultimately, what we want to do is have the right care at the right place, at the right time, at the right cost. And directly related to the events in life changes. So as you look at the patterns of utilization on the slide here, if we are able to intervene at certain points when certain events occur and deliver the right information and get the right care, we drive down our overall medical costs, and we drive the patient's outcomes and quality of life better. So ultimately, the stakeholders are four, right? You got to focus on big data from a patient, drive big data to make me healthier. From a doctor's point of view, I don't want to see patients that are well. I want to see patients that really need to see me and really need my expertise to deliver that care. Nurses want to be effective. So instead of going and delivering water to a patient, better serve their time delivering care to a patient and let the water be delivered by an orderly. And using the healthcare facilities and the technologies available to drive that interaction with the patient. So imagine, a patient sitting bedside and instead of clicking the nurse call button for the nurse to come and ultimately find out that he needs a glass of water, what if he went into the hospital and he picked up his Android phone and he downloaded an app from the Google App Store that basically said, hey, I need some water, and that request then got dispatched to an orderly as opposed to the nurse. And administrators will love big data as long as we can drive the efficiencies and effectiveness of care to patients and employees. With that.
Great.
Thank you.
Thanks, Dan. I'm not last. Sorry about that. They're saving the best for last, though. So, hey everyone, thanks for your time this afternoon. I really want to talk about, how the cloud can help us address the big data challenge around DNA or genome sequencing data. And Jan showed us earlier some of the stats around that. And actually, everybody's DNA sequence or whole genome sequence actually takes about close to 1 terabyte of storage space. So when you add in the raw data and then the aligning or mapping or analysis that you do on that raw data, you get close to 1 terabyte of data per person, per one person's whole genome sequence. So definitely have a big data challenge in front of us. And just to look at history a little bit, and some of you may know this, so I apologize. But the first first whole human genome sequence was done back in 2003, and this took several years to do the sequence, and it cost multiple billions of dollars. Since 2003, we've seen really a dramatic improvement in the efficiency in generating the sequence, and really a precipitous drop in the cost of the sequence. In fact, it's been about a 10x improvement every 2 years. And you compare that to actually Moore's Law, which has shown about a 2x improvement every 2 years. So really a significant improvement in that productivity. On the right, your right, yep. You'll see some of the costs to generate your whole genome sequence now. So in 2008, it was $300,000, and now it's $3,000 approximately. It'll probably be about $1,000 by the end of the year. So dramatic decrease in cost. So what's that doing for us? Well, it's really moving the bottleneck or the challenge from sequencing your DNA now to analyzing your DNA. All right, we've reached a point now, and it will continue to drop. It's highly likely that the cost to sequence your whole genome will be about $100 in a couple of years. So now we've got a big data challenge in being able to effectively and efficiently analyze, a terabyte of data per person. So that's really where we're at, and of course the cloud comes in pretty handy in terms of helping us to do this, right? It's elastic, so you can scale up and down quickly. It's very economic for consumers and users of the cloud. You really have unlimited storage and compute capacity, and the data is centralized, which is really critical to collaboration. At DNA Nexus, we are a cloud-based solution to store, manage, and analyze DNA or genome sequencing data. Our mission is to unlock the potential of DNA-based medicine and biotechnology with a collaborative and scalable platform. And so really, I think of 3 things here. We're offering a best-of-breed platform for analytical tools, right? So best of breed in terms of how we're going to analyze the data. What types of workflows or pipelines are we going to build? What are those analytical engines? Second is we want to foster collaboration to help accelerate research. And the third is to make sure that we've addressed the security requirements of customers in order to help them meet their regulatory requirements. So best of breed analytical tools, foster collaboration, and ultimately deliver the security that customers need. So just taking a look at collaboration first here, to accelerate the research, which is really what this is all about, collaboration is important. And it's pretty hard to move these massive amounts of data around the globe. So with the cloud, of course, if we can store it in one centralized place, we don't need to move it. Makes it fairly easy for a researcher to share an analysis on the data or even share the data itself, whether it's across the country or across the globe. And even when you look at within the clinic, being able to collaborate among different roles, you know, whether you're a researcher or a tester or a nurse or a doctor or a counselor, you want to be able to effectively collaborate on this, you know, very critical and important patient data. So cloud is really effective at moving along the collaboration. In terms of security, you know, certainly what we've done and what we see a lot of you know, successful cloud providers doing is they're architecting security into their solution from the ground up. In my experience, I've been in the cloud space for a while, and up until a couple of years ago, maybe 1 to 2 years ago, a lot of my discussion with customers was around the benefits of the cloud. You know, customers were questioning the benefits. Is it more efficient? Does it cost me less? You know, does it accelerate innovation? And largely, in the last 1 or 2 years, those discussions have stopped. Customers now aren't questioning the benefits of the cloud. They get it, they accept it, but they are still concerned about security. Security continues to be that primary concern or inhibitor to adopting cloud solutions. And so we think it's very important to ensure that we've architected that from the ground up. You know, at the same time, when I talk to customers, you know, I say, look, you know, a cloud-based solution is actually often more secure than a solution that you could deploy on your own on-premise. And I get some quizzical looks from customers around that. But when you think about it, you know, the cloud provider, ensuring the security of a customer's data is their lifeblood. You know, so a cloud provider is going to have the domain expertise and the core competency around security to ensure that, again, they're meeting the requirements of their customers. And you know, in our particular case, that's making sure that we've got the right controls in place, the processes, the procedures, so that our customers can be HIPAA compliant or CLIA compliant or CFR, you know, whatever the specific regulatory requirements are. It's important for us to be able to support that and not just be not an obstacle, but actually an enabler of our customers meeting those regulatory requirements. At the same time, it's still a partnership. No matter what we put in place, there's still things that the customer has to do on their end. I saw some data actually a couple of days ago that said that 85% of the HIPAA breaches in the US last year were due to lost or stolen media, and 92% of those cases were a lost or stolen laptop. So the data was on the laptop. So again, when you think about it, just by putting the data in the cloud in one place in a centralized location, you're mitigating against your HIPAA exposure. So we got a lot of work to do, I think, as an industry to help customers understand how the cloud can actually really benefit and enable their security. You know, ultimately, as I said earlier, this is really about accelerating their research. You know, we see our role as making it incredibly easy for the researcher to do their job. Right? Driving that ease of use at multiple vectors, whether that's collaboration, whether that's security, whether that's the right analytical tools and best-in-breed analytical tools, but making it easy for the researcher to do their job. If we make that easy, we should accelerate research and ultimately drive towards more deterministic treatment for the patient based on DNA or genome sequencing data. And you know, you'll see in the map here, coming full circle, the patient's providing a sample, that DNA is getting sequenced. Right now, the vast majority of the work is being done on the research side to, again, develop deterministic treatment for doctors to take advantage of, ultimately improve medical treatment for patients, personalized medicine, as was talked about earlier. And there's some cases where that's being used today. For those of you that, again, may or may not be familiar with this, there was a front page article in the New York Times a couple of weeks ago where DNA sequencing data has been used by doctors in the clinic for cancer treatment. Right? So right now, sequencing is being done on the cancerous cells, excuse me, and then on the person's regular cells or non-cancerous cells, and comparisons are being made to then highly target drugs and treatments based on the specific gene that's mutating. It's also being used in the clinic today to identify Mendelian or rare genetic disorders. So there is some applicable use cases today, but we're a long way from the state where the patient, you know, goes into the doctor's office, and the doctor orders a blood test and a DNA sequence. And based on that, actually gets some real actionable insight and actionable results for the patient to be able to take advantage of. And that's where coming back to making it easy for the researcher to do their work now will hopefully help us get there. So Jan and Chris did ask for a couple of calls to action. So here are my couple of ones. The first is around security. Again, with that being the biggest concern, I think as an industry, if we can work together to standardize certifications, that will help give customers confidence that their cloud provider is meeting their security needs. Right? If we reach a level of standard where, if you meet this certification, there's a high degree of predictability of what that means. And then for a customer, they know that, hey, this cloud provider is going to meet my security needs. And the other is very simply driving adoption of cloud-based solutions. Again, I think it's very clear now we've reached an inflection point where people aren't really questioning the benefits of the cloud. And if that's the case and the cloud can help all of us in this room and in our industry and in the world benefit from DNA-based medicine, then hey, let's get researchers using something that will help all of us in the end game. So thank you very much.
Oh yeah. Well, thank you. It's a real privilege to be invited to speak to this group. I will try to keep it entertaining. We're going to talk about paradigm shifts in healthcare, and I think I'll start with a story today. I work in a company, I run a company 6 days a week. We're one of the technology leaders in unstructured data. I also work 1 day a week as a doctor. A couple of weeks ago, I was in a hospital. I work out of the Stanford affiliate hospitals, and some of the residents were coming to me asking me, we have this really challenging patient. We have a very nice guy who had a complicated appendicitis, a tough operation, an open abdomen, and that happens. And we're trying to figure out what the best approach is. They said, Dr. Riskin, you're an intensive care doctor and a surgeon. We thought you might know, and help us to figure out what would be the right thing to do for this patient. And I looked him in the eye and I said, I don't know. No one knows. And the reason is, in our modern paradigm of healthcare, the only way you know is when you do a randomized trial. You split people into one group, another group, you try each different approach. One works, one doesn't work as well, you pick. The problem with that is it costs a lot of money. It's only done on certain types of conditions that appear in a large population. And so while this condition of a complicated appendicitis happens a lot, there are thousands of people who have had this, and while the knowledge is out there of what the best approach is, no one knows the answer. No one's been able to figure it out. That's a big data problem. So roughly every 50 years in healthcare, there's a revolutionary change. Back in the 1870s, we had Lister and Pasteur, the germ theory of disease, and a transition of healthcare toward public health, probably the most meaningful change in healthcare that's ever happened. In the 1920s, we saw penicillin discovered. We saw a focus in medications to change the face of healthcare. Quite meaningful, really determined the face of healthcare for the 20th century. By the 1970s, we saw a huge paradigm shift that was related to ethical violations all the way from Nazi Germany through Tuskegee syphilis trials, and a definition that medicine should no longer be just an art but should have science associated. The randomized trial, split people up, see what works better, change healthcare based on evidence. Terrific. So the question that comes up is what happens next? Every 50 years, I think we're coming to believe it, 2020s, what happens? And we'll take that adventure today over the next 10 minutes or so. So this is where I started when I was in my training in the 90s. Big surgeon, big operation, big incision, that's what you do. Very quickly, I started being trained in minimally invasive operations, great advance. All of a sudden, data starts flowing into what I do. All of a sudden, you see here the MRI suite or the CT suite influencing care, and you see transatlantic operations and robots. And then very quickly, toward the end of my training, the imaging gets integrated with interventions, and you see real-time MRIs with catheters and the approach of using catheters for intervention. And all of a sudden, data begins defining healthcare. And I say this by way of leading up to the answer to what is the next big thing. So over the last decade, the lines have blurred. It used to be diagnosis was data and intervention was what we did with a scalpel. Then all of a sudden, intervention was a catheter, and now very rapidly, intervention is using the data. Data underlies everything we do that's forward-looking in healthcare. So this is no longer relevant. Tools of my old trade, a scalpel, a clamp. Now this is relevant. This is imaging that got reconstructed, and we can intervene based on this imaging of an aorta where we see a aneurysm that potentially is about to rupture. And this is what's relevant in the ICU, what I see when I work. Data, just flowing through thousands of data pieces a day for any given patient going into the electronic health record. And so the question becomes, what are the major trends, the leading trends that are defining this next paradigm shift? Well, the answer is one, clearly big data. Just like the transition to public health was created by Lister and Pasteur and others, we've got these trends. So big data is flowing over from IT, from consumer IT and the internet. The tools are being created, natural language processing, ontologies, data mining. I wish I could say healthcare created this. We're certainly learning from it. We've never actually saved money or improved quality without a feedback loop, without measure, intervene, measure. So we're starting to get it. We need the tools. And then IT oversight. If you're a patient, you'd rather go to the place with decent IT oversight. Protocols, tracking, quality assurance. Kaiser's one of the leaders in this. So if this is current data in healthcare, where for a given visit you have an electronic health record and you might note 2 different findings, and if this is big data in healthcare, where for a given patient on a given encounter, you have this entire note documented, which is why the doctors complain, because all this information is in there and unused, then the future ends up being big data in healthcare. You have a patient who has an office visit, a hospitalization, an intervention. What happened? That guy with appendicitis, how did he do? You tried treating one guy this way and the other one another way. How did that work out based on flowing thousands of data pieces through the system and understanding what the best approach is, not only for that disease, but perhaps even for this individual and perhaps even for this genome in this individual? So we'll take a look at a short animation now because I do like to show really what's happening with the data. If you could start that, please. So we're talking about data-driven healthcare. And what we'll describe here is full clinical data, which is to say all the content being entered into the medical chart on every patient. So we've already heard that about 80% of the content is unstructured and unusable. The technologies are now here to allow us to actually use the data. And this is what the data look like. It's a history of present illness. A 78-year-old woman comes in with a specific condition. And there are certain pieces of information that are meaningful. And here we pull out the pieces of meaningful information. Now those pieces of meaningful information need to be put into context, whether it's chief complaint or a medical history or a present illness problem. Then the terminologies which are available in healthcare, and I know I'm speaking to an IT crowd, so I'm not going to overwhelm you with this stuff. The terminologies provide consistency, the ontologies provide relationships between the words, and once you've developed out the relationships, you can actually see what's going on with a person at a computational level. The history, the 20 notes that preceded this patient, or the last year of notes, or the last 10 year of notes, provides the context. So you can pull out that this patient is a smoker, or has obstructive pulmonary disease or asthma. And with that context, you can actually figure out meaningful information. So the first application we see is clinical decision support. Pulling out the meaningful information, you can see that this may be a pneumonia, but you should rule out heart attack. This patient needs follow-up for smoking cessation and might need evaluation for cardiac disease. So if that's how this plays out with one patient, how does this play out with multiple patients? So you can pull out an entire record, and now you're talking about thousands of notes for a given patient, or more if you're looking at an older patient, and you can map that patient, pulling out hundreds of thousands or millions of data pieces, and you can find the key pieces of information, whether you need annual screening or whether you need a treatment. And then you pull out to an entire population, based on the electronic medical record, which allows you population-based support to say, we're going to treat this population better. And this is how Kaiser views the world and some of the other leading institutions. So let's look at advanced applications. And here we get into the really hard stuff, subgroup analytics. Taking big sets of patient records, you can actually pull out a specific group of people, men 60 to 69, discharged from the hospital. You can figure out what works for some people and what didn't work. Who gets readmitted to the hospital? This is the core underlying expense for healthcare here. We can find out that it just was an easy issue. They didn't fill their prescription. They had a high blood pressure afterwards. We don't know what these issues are for these cohorts because we've never run the data. But once you find the data, it is possible to figure out where the patients fit, what the key issues were, have an intervention to actually create quality, and then once the intervention is complete, actually measure the outcome. Now, this is no longer done at the level of people manually writing down a registry for patients. This is done at an automated level to improve quality and reduce costs. So what we see in the country, hopefully a country which is ready to take the lead in data-driven healthcare, we're putting a lot of money to it. This addresses quality improvement, efficiency, and countless other parts of the healthcare system. So I'm happy to be a part of it. I'll move on to the next slide so that we can jump into the end of the discussion. So this is a revolution in healthcare. We're shifting innovation to mature platforms. There's more rapid innovation. Here you see groups separating out. We might have an expert on the panel on genomics. You might have an expert on natural language processing and unstructured data. You might have an expert on care implementation and paradigms, or an expert on large enterprise implementations, or on funding the toughest innovation that's coming out. So we use data to drive the changes in healthcare. We address the fundamental flaws of what we set up 50 years ago, and we define the new standard of care. This revolution just began. You're looking at about 2 years into the revolution of data-driven healthcare. All the publications are within the last 2 years. Each of these institutions used unstructured data to influence care. It's a first, and it's a massive change in the practice of healthcare. So we're at the beginning of a journey. The call to action is, healthcare is no longer about doctors making healthcare better. Healthcare is now about experts from all fields coming together, working with the data, and changing the system. So it's a call to action for the audience. Thank you.
Thank you, Dan. This is a really fantastic presentation. We do have a number of experts from different domains here, but before we get into the Q&A, let's give them a round of applause. Thank you, guys. If you have a question, just raise your hand, but we have, how many minutes do we have, Chris? 10 minutes? Okay. One question I thought I'd like to pose is, we all know that innovation in healthcare is very difficult. We know that there are many barriers, many challenges, but from your points of view, from where you come from, what do you suggest are the 1 or 2 areas that we should focus on? And keeping in mind, this is an audience that has IT, academics, and a lot of researchers, and some investors. So let's start with Ajit. You want to start?
So if you broadly define care, and split it between diagnostics and therapeutics. I'm oversimplifying it just to make a point. There are other areas as well. Diagnostics is about 3% of total healthcare expense, but it impacts 70% of the expense downstream. And it impacts all of the quality of care downstream. So 100% of quality of therapeutics and 70% of the total cost is impacted by something that comes upstream that's 3%. So ask yourself, should we be thinking in terms of companion diagnostics to good therapies, or should we be thinking in terms of companion therapeutics for good diagnostics? So a broad trend in innovation that I'd like to see being funded, being nurtured, is emphasis on diagnostics.
Issues number 1, 2, and 3 are systems. It's all about systems. 50 years ago, if I had to choose between the doctor who is practicing medicine as an art or the new breed of doctor who is practicing medicine as a science, you bet you know who I'd choose. These days, if I had to choose between the hospital with a great reputation versus the one that's implementing great systems, I choose the one with systems every day. Better be IT enabled too.
Great. In my specific space, I think the biggest challenge is getting the researchers and the clinic comfortable putting the data in the cloud. Comfortable putting a patient's genome sequence in the cloud. That's the biggest challenge faced today for us.
I think folks focus on the wrong things. I think they focus on big things, big IT projects, big data, as opposed to focusing on what is the most important. What is the outcome? Whether it's an outcome for a patient, whether it's an outcome for a doctor, whether it's an outcome for a nurse, really need to be focusing on the use cases that drive outcomes.
I think for myself, I think there's a trade-off between IT and the human part of it, human part of medicine. And the biggest challenge going forward, I think, is to find out where that line is. I think for many, many years, the systems that have been designed for medicine come out of IT. And so going forward, I see a lot of interesting things that are happening that are very encouraging, which is helping the physicians to be more productive, to do the things they're trained to do, and where they can uniquely supply value. And that question of where the automation should happen and how it should happen and who should accept it, who shouldn't, whether patients will accept that or not, I think that's a big issue. And that has a lot to do with whether, as a patient, you accept that, you accept automation, as opposed to the human touch, or both. And so I think the challenge going forward is to make those systems, in a sense, so smart that the physician can be a super physician where they need to be, and they allow non-physicians to practice healthcare as well. And for the part that needs to be automated can be automated. I think that's a real big challenge. Any questions from the audience? Yes. Yes. Yes.
Privacy and compliance was not stressed enough in the panel, I thought. So I'd like to know by experience from each of you.
Okay.
Has been a hindrance in innovation.
Okay, so the question is, what about privacy and confidentiality? Where is the trade-off? How do we look to develop value from data when there's all the concerns about where the implications may be? So personal experience, opinions?
I can go ahead. I mean, it's of paramount importance to us, and we have these discussions every day with our customers. And there are a number of things that can be done. First and foremost, that certainly the data that we're storing can be anonymized, and so you're depersonalizing the information. But then, by doing that, that's certainly fine for us. You're moving the risk to the to the clinic or to the researcher that's holding the the translation of that data to the actual person. And I think it is a challenge. I talked about how data is predominantly being lost today and those breaches. And so there are certainly things that we can be doing. In my experience, and this supports the sort of factoid that I shared earlier, though, which is that systems are rarely the cause of data loss and data breaches. Primarily, the cause is a person and something that the person is doing. And so no matter how bulletproof you make the systems, there's still room for human intervention to cause a breakdown.
I agree completely with Marc. I think that we should be moving this to the cloud, fully encrypted transmission, appropriate protocols, and safety. The era of thinking that your patient record is safer sitting as a patient chart in a window of a doctor's office is gone. Even the idea of keeping this stuff locally in a hospital scares me. I want the best experts in the world to be handling this in a centralized location with clear processes and systems in place. And the idea that healthcare has not figured that out yet scares me, but I think we'll get there within the next few years.
I think, one of the interesting things why this topic continues to come up, it's because traditionally security is an afterthought. And so we have to, as we're building the systems of the future, security needs to be built in from the ground up. And it starts with the data. And it starts with the role also. So, if you think of a doctor and a patient, right? So a doctor's going to have access to a certain amount of information for that patient, but what if the doctor was the patient? So does their role change? Does their access to that information change? You bet, right? So getting the systems and building the technologies that contemplate context of the interaction or the engagement with the data and the role that that individual has with the data is where we need to be driving in the future.
Two-part answers. First, a very conformist one, and then a bit provocative. So this problem is not science limited. This is not technology limited. This is not engineering limited. It is systems limited. It's truly the level of execution you've been able to do or not able to do that determines how safe or secure it is. Now, the provocative part, if I make a list of top 10 problems that healthcare information systems ought to solve in the next 20 years, this is not one of them. So it's a relative importance. To the extent a data is not corrupted, to the extent you've solved the corruption problem, rest of it has absolutely no relevance for patient care. Zero. Is it important? Yes. I'm not saying data security is important. There's no question about it. Will it do anything, even an iota of improvement of patient care? The answer is zero. So if you would like a dialogue on this, we should do it over a glass of wine.
And I think from my point of view, security is always relative, right? It's not binary. And so that does bring up the question of what is the value of the data and what is the appropriate security and how does the patient understand what the value of the data is that they may or may not own. And I think that does bring up some interesting models for the future, such as information exchange, information markets. People always ask me a lot about, when I deal with telehealth, what do patients say about having a device in their home monitoring them? And then I always say, it's a trade-off. If the trade-off is that if you don't have the device, you have to be in a nursing home, that's a trade-off. That's value to that information. So then they're very willing to do that. So I think it's all very much relative. I mean, there are patients, for instance, who would love to sell their information to a research organization, improve medical care for the future, and be paid for it. So I think it has many dimensions to it. I see Chris over here looking nervously. Okay.
In fact, I might draw that picture. Rob, if you want to make some comments, Rob is from Washington, D.C. He is the president of IIF. This whole healthcare and IT and government policy and security is a big business in Washington, D.C. Do you want to say a few words?
Sure, the only word I would say would be there is a deep level of this. The sooner we get to your vision, the happier I'll be. So I'm 100% behind this, as we have been for years. But there is such steep distrust in Washington. You tell people, yes, it's possible to anonymize data sets, and they will say, no, it's not. You cannot anonymize data sets. You say, it's possible to have secure data storage. No, it's not possible to have secure data storage. So I wouldn't underestimate the very, very deep level of distrust in Washington that we should go down this path. Even with all of the, you can imagine sort of, should we go down this path with marketing, gizmos on Facebook, maybe there's some privacy things. You can weigh it either way. But we're talking about saving people's lives and dramatically improving people's health. And even with that as the big giant benefit, there are a lot of active groups in Washington that don't want this to happen.
It's interesting. So essentially you could create different classes of patients, people who have disclosed, people who don't want the disclosure. It's just a very interesting, the implications of that. And there was a question over here? Oh, yeah. Oh, hi.
Okay. I may not look, but I'm old enough to have been through a time when expert systems would solve all problems. And I work with social media data. And what we are seeing is that what we can extract from information is not useful. And what is useful we cannot extract. So my question for this panel is, how much hype we have with this and how much actual results we are really seeing right now that really make us believe that this is real? I wonder if you have examples that you could share with us.
Yeah, I think we're 90% hype at this point. We're probably about 2 years into this revolution, and if you look at the types of change that make it into New England Journal of Medicine, it's I changed my thought on this one patient based on my population, which is tremendous. It's a great kind of thought-provoking piece. But the actual change in healthcare, we're years away. When many of us worked at the political level 4 or 5 years ago, envisioning the shift to electronic health records, most of us thought that the first 5 to 10 years would have no meaningful benefit for patients. And it was, at least several of us felt that it was an infrastructure play, creating the roads that would later allow for analytics, quality improvement, and cost reduction. And I think I still believe what I did back then, which is we're just now getting to the point where analytics are meaningfully possible on the level of data that we're collecting. So it remains a big data problem, which is to say beyond current means. And I'm hoping within the next few years we'll actually see meaningful changes in care.
Nothing to add.
Yeah, it's a very new field, and like Dan was saying, and actually we're shifting not just from sort of traditional care to data-driven care, we're actually switching from RCT care to data-driven care, correlational care, and that's a very big step, for physicians to say, there's no RCT evidence behind this, but we have lots of data. So the statistics are that this is going to happen, and to practice medicine like that, that's a huge shift. So I'd like to end by asking each of our panelists to just give a call of action to this group, what you think this group should be doing and what we can perhaps work on together. And at the end, I'm going to also ask for ideas from the audience, because this is, SRI is a unique organization on service research. And with its audience, what would be profitable, what would be fruitful, what do you think near term we should be doing?
So my comment is not instructive, or it's more prescriptive than it's instructive. Two broad themes. So if you take on projects, if you finance projects, if you work on projects, look for these two important principles. Number one, the traditional approach to integration that is achieved at the time of design will have no relevance in the future. Something akin to search and aggregate. So integrate on demand via search and aggregate will have a more critical role. Second, if you see any effort to model and reduce, avoid it. This is an extremely complex problem with too many interdependencies. So I'll make a provocative statement. The data itself is the knowledge. The data itself is the model. Any effect to reduce the data to a model a priori, non-emergent, is misguided. So look for those two broad principles in the projects you get involved in.
My call to action is really a pet project of mine. I've been watching for decades IT, consumer IT, run past healthcare. And it's because healthcare organizations find a need to silo and build these monolithic applications that are locally bound. It slows innovation, and it's quite frankly depressing. We're watching best-of-breed technologies come out, early stage companies that have amazing technologies. And the call to action is, look at the modules that can do something meaningful, and with your big companies, bring those in, use best-of-breed technologies, do rapid innovation. That's where I'm really hoping healthcare will go over the next few years.
Yeah, mine's pretty similar. I think, just helping the life sciences market, companies, businesses, institutions, healthcare, take advantage of the emerging technologies that will ultimately, benefit all of us in the long run.
So if you focus on, really focus on one thing, right? Pick a use case, and do that and build that and solution that use case, you know, and don't focus on, you know, solving world hunger. Focus on one problem and one problem only and drill it until it's done. As you've heard, you know, throughout the panel, you know, there's 10,000 use cases, right? And so come up with the solution. You know, there's many people in the room, so pick one of those 10,000 use cases and do it well. And then that fosters the innovation that the larger companies can then go pull those pieces together and integrate them and drive the outcomes that we're looking for from the doctors, patients, and nurses.
Thank you. And I think from my perspective, I think from what I've seen in the work I do, the innovation will probably take shorter if it doesn't touch clinical care. And so if you look at health IT, there's a lot of stuff in health IT that actually doesn't really deal with clinical care. And so you don't have to go the regulatory path. You don't have to put up a lot of money to go through FDA and so on. I think I would probably look for those kind of technologies. If you see technologies that could improve productivity by automating a generic function, that's worth looking into for healthcare. Because healthcare, it lags. That's all I can say. Let's give our panel another round of applause, our distinguished panel.